introduction, I am a psychiatrist, and the reason I've been involved in this research and work for the last 15 years is because I trained in cognitive behaviour therapy in London with Professor Isaac Marks around about 1990. And then I am still working at Flinders Medical Centre, which is a major teaching hospital in Adelaide in South Australia. And my PhD was in the overlap between anxiety and chronic obstructive pulmonary disease. So I've had a lifelong interest in the overlap between physical and mental illness. And then through my work around cognitive behavioural treatments, particularly around anxiety disorders and problem gambling, Australians are the biggest gamblers in the world, believe it or not. I became really interested in behaviour change, generally speaking, and particularly as it applied to people with chronic diseases or chronic conditions. And for me, it was the overlap between mental disorder, physical disorder, and then how people can move forward, managing those conditions, but also managing their lives. And from a medical or psychiatric point of view, the whole biopsychosocial aspects of healthcare. That's sort of like where I've come from, and our team here at Flinders has been working in a wide range of areas, applying principles of self-management, and I'm going to touch on a couple of those today. So that's where we're heading from. I know that I understand that you're peer leaders in your own disciplines, and that you're innovators in terms of you're interested in digital applications in the health system. And I'm going to finish off by mentioning how we're applying these processes in a digital manner, as it turns out, not far from you in the United States. So, we'll try various ways of doing this. Okay. But our funding over the last 15 years has covered mainly state and federal governments, but also the Department of Veteran Affairs, and that's an important project that we're currently doing. We've also worked in Aboriginal Health, and that provides a very strong background to what we do. I'm going to really focus on patient-centred care and the overlap between patient-centred care and self-management support, and I'm going to finish off talking about implementation. And it's really from the point of view that every one of us have been to many, many training programs and then walked away full of enthusiasm, but never really worked out how to apply it in practice. And we've had some examples where we've actually been helped organisations apply these principles in practice. So, touch on patient-centred care. You walk into any room of any health professional and everyone puts their hand over their heart and says, I do patient-centred care. Then the challenge then is to say, what is it? How do you define it? Can you measure it? Does it make a difference? Is it really a warm, fuzzy thing that we have between us and our clients, our patients? Makes us all feel better, but does it really make a difference? And we've got some examples here where people provide definitions, people have come up with components of patient-centred care. And the bit that I really paid attention to in this slide or definition is the last one. It does not mean giving patients whatever they want. Rather, patients want guidance from their care providers, but they expect that guidance to be provided in the context of full and unbiased information about options, benefits, and risks, which really goes into the whole thing about being a partnership. And so patient-centred care is more than just being nice and letting the patient make most of the decisions. It's really having a balance where we do have a very important and powerful role in that whole process. Other definitions or components start to try and tease apart what happens in patient-centred care, the reason for the visit, understanding of the whole person, common ground, enhancing prevention, and the relationship itself is all part of that. But somebody would ask the obvious question, does it make any difference in terms of outcomes if people are better at patient-centred care? And there is now some reasonable evidence around actual clinical outcomes being improved by more components or implementing patient-centred care. Another term that's been in the literature is around patient engagement. And that's why I want to explore these overlaps between patient engagement, patient-centered care, and self-management. So you've got these dimensions about communication, patient incentive, and again, more engaged patients have perceived better health outcomes, and patient-centered care leads to higher levels of patient engagement. So this led us, or this is the background to a study that we were funded to do in Australia with this team of chief investigators and Tony Delaney. And it was to try and look at what actually is happening in practice in terms of communication and patient-centered care. And the background to this was in Australia, we've actually got a funded health system, funded for chronic disease management or chronic disease care planning. A family practitioner will be paid about $125 to do a team care plan, and they get a supplementary $85 roughly to add on to that what's called a team care arrangement, which enables 5 sessions of allied health to be paid for by the federal government. So people quite rightly ask, what's the evidence around care planning? So limited success. Patients do not generally expect to participate, which detracts from the possibility of genuine collaboration. So that jumped ahead quite a bit. So we conducted this study at rural and metropolitan sites. It was a quantitative and qualitative process. Clients had multiple chronic conditions, some Aboriginal clients. A community health centre was included as part of that. And so there were questions in semi-structured interviews to patients as well as practitioners, GPs and community and allied health staff, trying to tease apart what the interaction was with their care providers around care planning. The project officer actually also added in observations and focus groups. She actually sat in on a lot of interactions between GPs and their patients, and between health professionals and their patients, and did focus groups. The survey was conducted across a wide range of practitioners, and you can see the numbers there. And the results were that, and I guess this is not rocket science, but it's actually important to confirm what we intuitively might guess, that greater participation in decision and planning allowed a more equal flow of information which assisted positive outcomes. It's important to provide an opportunity for the patient to participate. If it's written down for them, sometimes they are actually very proactive. They start to self-initiate. Shared decision-making was that 72% agreed that one purpose of a care plan is to engage patients, and that the shared decision-making is one of the indicators of the care plan success. However, all people involved in this process were concerned about fragmented communication. And that is from both the client's, the patient's point of view, but also from the individual practitioners not receiving feedback from their other clinicians. And obviously they're at one end of the spectrum, but they're also at the other end of the spectrum, probably not providing feedback themselves as well. So that what we wanted to really narrow it down is, what is it about the communication process that works or doesn't work? And we came across this evidence of the idea of closed questioning, or patients felt that they were devalued by closed questions. And that's a really good example. A nurse asked me these questions. It was almost like A, B, or C. She didn't want to hear anything else. When I started saying no, she said, I want an answer. I want A, B, and C. And someone else had said, we don't really all fit into that box, do we? And I think when I was reading some of these, or summaries of the transcripts, I could identify in myself, as the caring, helpful, generous psychiatrist. On a bad day, and my time is running out, I probably slipped into some of these kind of habits myself. The other issue that we identified was the issue of control. Positive examples of shared control. Sometimes control was taken by the patient. Sometimes control was relinquished by the worker. But there are other examples of the control becoming a belittling or condescending approach by the health professional. And other times it was even became kind of a joint dependency where control was shared, but it was almost in a pathological kind of way. One of the other bits of what we we evidence with unconscious control, and I think this summarises the point we're really trying to make here. And this is from some other previous research by Stein Parbury, which is talking about nurses, but I think this could apply to all of us. The idea that we end up doing more talking than listening, evaluating more than understanding, leading more than following, and advising more than informing. So we came up with a set of recommendations around how we could address barriers and enablers to shared information. And we are going to be providing this, and this is part of a publication. I'm going to provide a list of publications at the end of this talk, but these slides will be available. And some of it, of how to address these issues, is a training and process issue between we as clinicians and our clients. Some of it's structural, and this is where I think digital e-health systems should be able to help rather than hinder this process. And I think you, like us, have been in the process of rolling out e-health solutions, and sometimes it doesn't go that well. Sometimes the feedback from clinicians is, you're making my life harder than easier. And if the ultimate purpose of this is to improve our communication between each other, but also information sharing, then we need to look at ways that we can actually improve implementation of digital systems. So these are sort of general recommendations about reducing duplication, and one of the components in the Australian system was to identify that practice nurses, family practice, general practice nurses, provide a key pivotal role, and to that extent the Australian government's actually been funding practice nurses much more over recent years to do this kind of work, but also in one particular program, which I'll mention later, the Coordinated Veterans Care Program, funds them explicitly to do these roles. So we've talked about patient-centred care, we've talked about patient engagement, and we've found some of the key elements within current practice in Australia anyway, where there's barriers to having patient-centred care and patient engagement. So I now want to talk about how we try to apply some of our learnings through the kind of self-management support model, which I'm assuming most people know is part of the chronic care model. Now, the original way that I got involved in this process was literally a tap on the shoulder in our hospital from Professor Peter McDonald, who was leading a new coordinated care project. And he had an epiphany because he was the chairman of the Australian AIDS and HIV task force, where what turned out to be mainly the gay community got really involved in the development of the clinical model. And I mean by real development. They weren't token people sitting on the side. And over about a 5-year period, the outcomes for people that are receiving care improved dramatically for HIV/AIDS in Australia. And at one stage, well, not whether we still do, we had one of the best outcomes for our clinical group. And what he saw was by having an evidence-based process, as in medical evidence, combined with engaged consumers, you could actually lead to a better outcome. So this led to the National Coordinated Care Trials, and I was asked to help set up a process, a generalised or a generic clinical process to develop care plans within which self-management support would be a centrepiece. So halfway through the trial, about a year into the trial, 2-year trial, we had about 30 coordinators together. They're mainly nurses, but allied health professionals, and asked what worked and what didn't work. And we'd come up with what we thought was a fairly sophisticated model about dividing diseases. We had 8 disease or project groups around diabetes, heart failure, respiratory disease, etc. And each one of those teams had come up with classifications for high, medium and low severity, which would then lead to services, but also hours of coordination. So if you're in high severity, you would get 18 hours of coordination per year, then 12, then 6. So the coordinator said, we aren't using that model. We just don't use the kind of high, medium and low severity to allocate coordination. And I remember thinking, well, I don't know whether I thought, I just had like a small brain explosion at the time, and then and said something like, well, what the hell do you do? And someone said, we give coordination based on whether a person is a good self-manager or not. So to me, that was the epiphany. And 30 heads nodded when the person said that. And I said, what do you mean by that? And they said, well, you can have someone who's in the severe category, but they're a great self-manager. They've got good relationships with their family practitioner and the other health professionals. They've got a supportive family. Financially, they're okay. They do not need me at all. Whereas the other guy, who's early in their diagnosis, lots of psychosocial issues, not motivated, etc., they're the person I need to work with. So we were given the challenge by the trial committee to come up with, to ask the question really, is there an objective clinical way which you can assess somebody's self-management? And part of the rationale for that was so we can then triage or provide the coordination for the right person at the right time and not waste resources. The second reason, or secondary reason, was then also perhaps develop a more targeted self-management approach, which would then improve our health outcomes as well. And that's led to what we now call the Flinders Program. So we started to study this more in our client groups and also looked at the literature. And there was also, the kind of when you teased it apart, self-management capacity was modulated by the illness. So severity definitely impacted on self-management. Personal attributes and critically attributes of health providers. You know, how good are we at encouraging, allowing or giving patients permission to be good self-managers? The last learning was around that not everybody needs self-management for a start-off, support, but those who do actually may respond to a wide range of methods, not just groups, not just books, not just the internet. So we started to analyse and think about what are we doing in our care planning processes, what works and what doesn't work. So in Australia, in our medical software, a family practitioner or a specialist could go in and hit the button for diabetes or heart failure or one of the others, and a drop-down box will appear which lists off all the basic medical management for diabetes or whatever condition. So what we were saying was, well, that's important. You need to have that. But what is the purpose of care planning? And what should it be derived from? And our first starting point was, let's ask the patient, first of all, what they already know about their diabetes and other conditions. What are their behaviours? What are their attitudes? What are the impacts of the condition? What are their risk factors? What are the barriers to self-management? What are their strengths? And these are the elements that we think a care plan should contain. And so, critically, it's the patient-defined problems as compared to our defined problems, their goals, medical management, etc., etc. In other words, a comprehensive care plan which covers all the medical conditions and psychosocial elements and provides a set of steps over a 12-month period to follow someone up. But if it's purely an administrative process which makes us feel good, then it's probably of no value. It's still of no value. It might be okay as a communication tool. That's good. That's okay. But if you're going to go to all this trouble, and especially if you're going to pay $100 or $200 to have it done, then it should do these things. It should actually engage and facilitate the patient's self-management. And what it should ultimately lead to is skill acquisition by the patient or client, which actually allows them to improve their self-management, their conditions, over a period of time. So we were funded over the last 5 years by the Commonwealth, the state, the federal government to get a national consensus around what is self-management, what is self-management support, and come up with the core capabilities for health professionals around supporting self-management. And that there are two large national projects. And this is a consensus definition of what we do as the health professionals, the system and family and carers. And this is the definition for an individual. And what we now call provides the 7 principles of self-management. And the idea of this definition is it's meant to cover all chronic diseases or people with multiple chronic diseases or conditions in the same person or amongst different population groups. And we've been testing this in mental health, children and adolescents, all sorts of physical conditions, basically to see if you can actually come up with a generic process. Having knowledge, adopting a plan you've agreed to, sharing decision-making, knowing what to monitor and manage and how to do it, managing the impacts of your conditions, adopting healthy lifestyles and having access and confidence in accessing these services. And why this is important is because many of us have been using language like self-care, self-management, and they're all quite legitimate terms. But one of the things I found, for example, is a lot of family practitioners we were talking to were thinking of self-management or self-care really about lifestyle management. Oh yes, these particular patients drink too much, or they don't exercise, or what have you. So we're saying our definition, or this national definition, actually covers all of those things. It incorporates medical self-management as well as lifestyle management and psychosocial self-management. We've been informed over the last few years by the amazing work of Susan Michie about behaviour change. You can get completely overwhelmed by the number of different behaviour change models, but we've tried to incorporate them, or we've tried to understand what we do in this kind of area. And one of the good things about Susan Michie's work is that she's listed off a whole range of evidence-based techniques. So whichever self-management or behaviour change models that you might be using in your own systems, it's a great taxonomy to look at to say, out of my team, the people I work with, who amongst us have got these skills, and what is the capability, motivation, opportunity that our individual patients have. Based around all of these things, we developed and evolved the Flinders program over time. So the program itself is a model for chronic condition management at the clinical level. It incorporates self-management, medical management, self-management, coaching and coordination. So if I had a service to run, a primary care service or a community or a hospital service, I'd be thinking in our processes, and again, how much of these can be supported by technology, how easy is it or how accessible is our medical management, self-management support, coaching and coordination. Now, not every single person who walks through our door will need coaching and coordination, but not everyone's going to need self-management support either. But it's sort of part of the checklist or the process we should go through to see whether people need this capability or not. So the Flinders program really is a way of, starts off with an assessment of self-management, then ask the person, out of all of your chronic conditions and other life issues, what do you think your main problem, main goal is? And out of that will come a clearly defined set of self-management, medical management, community and psychosocial supports, which is clearly documented on a care plan, and it's also clearly described as to who is responsible for which particular part of the process. And the way we've done that is by building a set of tools, the Partners in Health scale, which has now been validated and used internationally in Chinese and Spanish and a whole range of other languages. And then a cue and response interview, which the clinician does, and then those lead to, well, that's an example of the Partners in Health questions, self-rated 0 to 8 scale, what I know about my health conditions, what I know about the treatment, whether I take my medications. And the cue and response is the clinician's exploration of that same question. And we've broken it down into knowledge, attitudes and behaviour questions. But one of the main purposes of it is to explore what is the person doing already well, or what are the barriers to that person achieving that task. And again, the health professional rates that on a 0 to 8 scale and then compares it with the patient score. And once we've done that, we then say, what do you think is your main problem and what are the goals you want to achieve in the medium to long term? And if we were doing this as a workshop with medical students, I'd be saying, what on earth do you want to know? Why do you want to know what the person sees as their main problem when you know it's diabetes? And the obvious answer is, if you don't know what the person's main problem is, firstly, in terms of their life problem, first of all, you don't know what the biggest barrier to them achieving the best possible medical management is. So that part of them wants to be the best, stay well, to keep out of hospital. Another part of them is conflicted by life issues, employment, relationships, and all of those other things. If you don't know what that is, then you are going to get very frustrated as to why that person is not carrying out what you think is a sensible task. The second reason for finding out what their main problem is, that you now know what is the main thing that's going to motivate them to change. So again, that's where the goal comes in. So you find out what is the goal that's going to be achieved to improve that problem. And then what you're doing as a health professional is then to think, well, how can I link what I think are important medical goals with what this person believes are their main life goals? Now, some people got a bit intimidated, health professionals got intimidated by that kind of concept. And when this nearly 3,000 problem statements and goal statements were evaluated in the coordinated care trial, and about 70–75% of them were actually the main medical problem. In other words, we're not just creating some artificial psychosocial problem if it's not there. So about 20–30% of people had a psychosocial or similar kind of problem which needed to be addressed. But at least once you've done that process, you and the client, the patient, are on the same page. What this is summarised in there is a care plan which has got, we've only got part of the snapshot of this, goes across that column. So you've got their main problem and their main goal. We've got a 0 to 8 rating of all that. And across the column you can see one section which is who's the second to last written column, where you can see the person who's responsible for this care plan and when is it going to be reviewed. And just prior to that, what are the steps, the strategies that are going to be put into place to address what was one of the issues that came off of that cure and response interview. Once the care plan is created, then you've done half of the job. The next is about the follow-up and review and maintaining motivation and problem solving. So part of our training is teaching health professionals about motivational interviewing and how to help people learn problem solving, not to do it for them. But we would then recommend as one of the options for people to go and learn self-management skills that they'd either do either or both disease-specific self-management education, but also generic self-management education like the Stanford course. So we see a complete synergy between the Flinders process, the one-to-one process, and then a skill-based program, which is something like the Stanford program, which I know you're quite familiar with. When people say to us, the Flinders tools have got quite a lot of different steps or components, which are the main bits that actually work? And it almost goes back to the same question, which we often get asked: how can you tell which person is going to be motivated to do behaviour change? Who is the person that you should put your effort into? And I'll quite honestly tell you is I don't know. We don't have one gut feeling from a conversation with a patient which has ever been shown to be a predictor of outcomes over time. And our model is that you can't just by in a quick conversation or even knowing the history of a patient predict who will make changes depending on which motivational process you use. Our model is to say give everyone the benefit of the doubt. And what we find is that by doing this assessment, you can almost unpredictably find triggers or hooks where patients will kind of suddenly become more interested or concerned about and be more willing to take on their own healthcare. So it could happen in any one of those steps we've listed up there. And it's also a matter of repeating some of those where you might get change happening. I'm going to mention just one of our studies to illustrate the point. Vietnam veterans with alcohol problems, trial of the Flinders program. It was conducted in South Australia, in Adelaide, and we had 2 research nurses who were trained to use the Flinders tools, and they worked with a psychiatrist and the patient's family physician to use the care planning approach. we ended up with 77, I think, in the study overall. And as you can see, not surprisingly, most had post-traumatic stress disorder and depression, medical problems, as well as alcohol. They had to have an alcohol audit score over whatever the cutoff is, 2, I think, to get into the study. And over time, not just in the intervention period at 9 months, but also over 18 months, there was significant improvements in alcohol use in the audit scores, but also in DSM diagnosed alcohol dependence. Now, what was interesting about this was that when we asked the veteran what their main problem was, there was this wide range. The psychological condition, the alcohol was one main problem, but so was relationships, etc., etc. But when it came to working out what the goals were, alcohol was number 1 and relationships number 2, etc., etc. So, in other words, the person picked up the phone to come into the study because of alcohol, but once they went through a care planning process like this, there was a much more flexible approach about what thing do we need to work on with you today, which may then change over time. So goal 1 became goal 2, became goal 3 over time. So the nurses were actually quite skilled at saying, I'm going to work with you with what you see as your main problem, but ultimately they're probably saying either overtly or in their mind, we know we really need to work on your alcohol problem as well. So over time we've distilled or come up with a kind of a model around how does this all ultimately result in improvements in outcomes for patients. So what we've found is that even though there's pieces of paper sitting in front of you and the client, the patient, the way you talk about your conditions and your self-management has to incorporate patient engagement. It is not a matter of just putting a piece of paper in front of someone and saying, can we fill this in, please? So what we're assuming is that people are using all the normal skills and competencies about engagement to then lead into this process, which hopefully then leads to change in self-management behaviours, which will then improve clinical outcomes, which ultimately would improve quality of life and reductions in hospitalisation. But study after study around the world has shown that initially you'll get increased service utilisation as you empower patients to go off and actually get access to services they really need. But over time you'll get reductions in hospitalisation. So for some of us, this means that there's newly defined roles in the health system for practitioners, might not be everybody, but ability to assess self-management, overcome barriers, referring, having access to disease-specific education, generic self-management, and then use coaching and coordination skills. So the 2 main programs we've been funded for nationally are one focusing on Aboriginal health. We've got the worst life discrepancy in life expectancy than the even Canadian, American and New Zealand Indigenous populations. It's between 10 and 15 years, and the previous government established a program for that. We were just one part of a big program. And similarly, the Department of Veteran Affairs wanted to fund a program based around self-management for coordination, and I'm just going to touch on those briefly. We were funded to develop 4 online modules for the Veterans Coordinated Care Program around preparing services for chronic care management. The second one was around the clinical tools that I've discussed. The third module is about disease-specific programs, and the fourth is around mental health and social isolation. And towards the end of last year, we'd had over 2,500 to 3,000 people accessing either online or face-to-face versions of those training programs. And the lessons for us were that you needed to have both online and face-to-face. You shouldn't have just both. And we provided that sort of training across Australia. And we haven't been involved in implementation. We just provided these resources. And the evaluation of the program as a whole is still being developed. We're not formally part of that. But one of the aims of the program was to reduce hospitalisations, and the unofficial version of the outcomes is there's been reductions in the overall increase in hospitalisations that compared to a control group that they used, and there's been significant improvements in outcomes for clients. That's not a formal report as yet. But what we felt handicapped as a training unit during this program that we didn't have a role in implementation. What we were able to do was actually add this to our Indigenous programs for closing the gap. The first thing we did was adapt all of our tools to be culturally appropriate. So you can see this is a very different look in those previous black and white pages that I showed you, which were our standard forms for working with Australians with chronic disease. And this culturally adapted process made a massive difference in how we applied or people took up the tools in the Australian healthcare setting. And we created case studies or videos around Ethel. We adapted the tools to look like that, the care plan, and bringing together a cultural approach as well as a psychosocial approach is important. Now what I'm going to do is ask our team there, my wonderful technical support team, Caitlin, to show you a little video of a real patient or client who's gone through this program in Australia using the Flinders tools. And then I want to use this potentially as a way of having a bit of discussion at the end, if we've got enough time, which I think we will, because I'd really like you to pay attention to the different elements of the care that he's received, but also the changes in him and how he's related to his health professionals, and which I really think get to the heart of what I call patient-centred care.
Hi, my name's Peter Rose, and I'm 38 years old, and I'd like to tell you my story. About 13, 14 years ago, I got diagnosed with diabetes, and since then it's gone downhill, and my condition, I got other various diseases and conditions as well. And 2 years ago I ended up in hospital 3 times in a matter of 3 months, and that's when I met a lady from the Flinders Program, and she offered me to do a couple of courses and to do some training interviews with her. So I thought, well, might as well give it a go, because before that I'd only go out of the house. I was a hermit. I'd only go out to the doctors, and if I could I'd cancel that, so I wouldn't even have to go to that. And so I thought I'd give it a go, and I'd been living in Maryborough for 14 years and hadn't made any friends at all. I just kept to myself. And so Raylene started up a program where I went to do a training thing called CCs for people with chronic conditions and breath of fresh air. And I've been doing that for 2 years now, and in that 2 years I've got out of the wheelchair. I'm walking around now instead of being confined to the wheelchair all the time. And I've got my blood pressure under control. I've gone from 3 blood pressure tablets a day down to 1. I've got my diabetes under control, and I've also got my depression under control. I'm not on depressions anymore, and I've got that many friends I can't count it anymore. And instead of staying home all the time, I go out 4 days a week, and I've just recently got back to work as a volunteer at the hospital, helping other people with lung and heart disease. And that opened my eyes to how I should be interacting with my doctor instead of just taking everything what they say. Now I question what the doctor says, and I've got a work team together now with all the medical team that I've got, and in conjunction with that we all work together, and I get a choice in how my condition's treated. And now my condition don't run me anymore, I run my condition. And it's all thanks to the interviews with the Flinders Program, because it gave me the courage to get out there and do it. And before, if the doctor said, oh, you've got to go on this medication, even if I didn't like it, I'd take it. Where now, I'll say, well, I can't take that one, I don't like it, can I try another medication instead that'll do the same thing? And then we do that, and the doctor's quite happy to do that with me now. But before, I didn't have the courage to do it. So the Flinders questionnaires and answers gave me the courage to do that. And then also Raylene from the Flinders Program taught me into looking into my Aboriginal background, because when I was young, even though I'm Aboriginal descendant, I got white skin, and I got 9 brothers and sisters. 6 out of those brothers and sisters got dark skin, and the other ones that have got light skin. So because we had light skin, my mum told me not to tell anybody I was Aboriginal when we went to school, so we didn't get picked on all the time. And so thanks to Raylene, I've had the courage to look into my Aboriginal background, and now I'm looking into becoming an Aboriginal elder.
One of the things I really wanted to point out or highlight is that Raylene explained to me how in her small community there was a new program around chronic disease management, and Peter's name was on a list of people, and basically no one wanted to go and work with him because he was more or less written off as someone that was beyond help. And to me, this is an example of that we just can't predict who is going to be able to respond to these tools. And I'm not even going anywhere near saying that everyone will or should. There's no such program in the world that's perfect for everybody. But basically giving someone like that the benefit of the doubt is important. And the other important word to me was courage. Obviously, this relationship he developed with Raylene, but through the use of the tools and those questions, empowered him. And to the point where the way he described that shift in his confidence, I suppose, between he and his doctor and doctors, but he also talked about the team, working with the team, and then him controlling his illness. So to me, that's what I mean by patient-centred care. In other words, so all of the practitioners involved in his care at some level have been working in a patient-centred way, but he's had access to a set of tools which have been much more given a whole structure to this process, the whole purpose of which is to motivate him to take control of his life, and in particular his medical conditions. And it is through a patient-centred approach. We provided a lot of training in this program across Australia. I think it was about 1,500 people trained overall. And one of the slides I had there previously was that our model is to provide the training and then people can go on to become a trainer. And I think we ended up with about 50 or 60 trainers across Australia, about a quarter of whom were Indigenous. And we've now developed an online training version of those tools. Halfway through the training contract, I went back to the Commonwealth and said, we'll waste our money if we don't help implement this. So we developed an implementation. I'm going to skip over. We developed a tobacco version of these tools. Well, we developed a 12-step implementation process. And you'll notice, if you can see that slide properly, that right down the bottom, number 7 is the training. In other words, we provided a framework for organisations based around the chronic care model and the ACIC tool, which many of you will be familiar with, to see whether an organisation was ready to implement this kind of model so that the training wasn't wasted. And then part of the implementation support was that we could then follow up people who've been trained in communities. Sometimes we could go and visit them face-to-face or provide follow-up. But it meant that we needed to help them address the delivery design processes, the funding processes, not just and the training process, but even down to the job descriptions of the staff, which would need to include who is going to be doing this care planning or self-management approach. And by the end of our program, at the end of last year, we had over 40 organisations who were in either phase 2 or 3 of the implementation model. And the way we were measuring outcomes in this was not clinical outcomes, because we had to get, would have had to get so many ethics approvals. We ended up having 8 different ethics approvals to get qualitative data, but all organisations committed to documenting the number of care plans and the occasions of service after a care plan, and it ended up over 6,000 Aboriginal people and Torres Strait Island people had a care plan with over about nearly 60,000 occasions of service after care planning. I want to stick to the conclusion where we're up to, is that we've gone through this whole idea about the concept of patient-centred care and patient engagement, what communication problems and barriers there are to enable patients to be better self-managers, and then describe a set of tools, of practical clinical tools that I think allow us to implement patient-centred care and to the point where you can measure outcomes. And just for your information, we actually use these tools as a way of assessing medical students' ability to do self-management support and patient-centred care. They have to, in 7 minutes, they're asked to do complete certain sections of the Flinders tools. And we think we can measure the ability to deliver patient-centred care as well as self-management support. So our 2 online training programs, which I think might be accessible to you in Canada, are stated here. The exciting thing for us at the moment is that the university has funded the development of a web-based application of these Flinders tools called FlindCare, and this is currently being piloted in Allentown, Pennsylvania, not far from you. And Krista, who's the project leader there in Allentown, may at one stage be able to come and collaborate with your group if you get interested in that. So far, the pilots look very positive, and we're looking at ways, or the hospital system is looking at ways of incorporating the tools within their hospital electronic record system and expand it out to their main chronic disease programs. And I think that might be the end. It's been good to talk to you.